started the timer and here is your question. All right, so if you have read and understood, considering it communication skill station, kindly please begin.
Hello,
Hello.
my candidate number is 66.
Okay.
Okay, I'm Dr. Jahan, one of the senior house officer working under Mr. Mann at King's Hospital, and I'm willing to talk with Mr. X of Queen's Hospital. He is a vascular consultant, and I would like to talk about a patient. He might be develop acute limb ischemia, and we want to transfer this patient for the definitive treatment in your hospital. Can I confirm that I'm talking with Mr. X?
Yes, it's Mr. X talking. Can you please summarize
Okay,
your
sir.
case?
Yes, thank you for your kind response, sir. 54-year lady names Y admitted in the diagnosis with mild diverticulitis. Her symptom improves with intravenous fluids and antibiotic. She complains of sudden onset of acute and severe left lower limb pain. On examination, ECG shows atrial fibrillation with broad preventricular complex, where ABG showed metabolic acidosis with hypocalcemia. Arterial hypokalemia. Arterial duplex confirms acute limb ischemia. Now we want to transfer this patient into your premises, sir.
Okay, doctor. What could be the cause of this?
There may be
Why
a
you are
chance of
suspecting acute limb ischemia?
okay, as the patient has acute and severe left lower limb pain, and arterial duplex confirms it is a acute limb ischemia.
Okay. May I know how it could have occurred for her? Is there any risk factor for her to develop acute limb ischemia?
Um, Sir, the patient has mild diverticulitis, so there might be a chance of that it is not it was not a diverticulitis. Might be there chance of mesenteric ischemia, so that it happens.
Okay, is it urgent? And can we send it her tomorrow morning instead?
I might think it is urgent as there is needed of surgical intervention. Otherwise, she may lose her limb.
Okay. Do you need cardiologist to review for PVC before transfer?
So there might be a chance that this atrial fibrillation and preventricular complex is happening due to electrolyte imbalance. So we can do it after the transfer.
Okay. What do you think the presumed diagnosis of diverticulitis?
As we have presumed that she might have a mild diverticulitis and her symptoms was improved by intravenous fluid and antibiotics. But right now we are thinking about that it might be a chance of mesenteric ischemia.
Okay. What are your differential diagnoses?
Okay, so there may be acute diverticulitis, appendicitis, cholecystitis, perforated viscous, or mesenteric ischemia.
Okay. Do you want to scan the abdomen first?
Yes, but we can do the CT scan, CT with contrast after transferring of the patient um, to after seeing the renal function test is normal.
Okay. For the limb ischemia, what imaging would you like to do?
Okay, would like to do CT angiography, MRI angiography. abdominal X-ray, and CTs.
Okay. Do you want to anticoagulate with, and which molecule you would like to use and how much?
Okay, would like to use unfractionated heparin, 500 500 milligram bolus dose, 500 international unit bolus dose IV, then 15 international unit per kg per hour, and follow up should be done by APTT when it is 40 to 60 seconds.
Okay. So what type of ambulance you will arrange for her transfer?
Advanced life support ambulance with blue lighting.
So what would be your management plan for this patient?
Okay, I want to manage this patient according to care of critical and surgical patient. Then have to I have to treat the electrolyte imbalance, then atrial fibrillation, metabolic acidosis.
Okay, what will you tell her family?
Okay, I have to counseling the patient family that there is a sudden reduction of the blood flow to the limb, so it need urgent intervention. So we are transferring this patient to higher unit for better treatment.
Okay, thanks. You may transfer the patient.
Okay, considering
Thank
the
you so much, sir.
considering the patient has acute lung injury, what would be your primary intervention that you'll do?
Okay, first of all, I have to look for the limb is viable or not. If the limb is viable, we can do thrombolysis, embolectomy, with or
Yes.
without fasciotomy in the presence of compartment syndrome or not. If it is not viable, then we'll go for amputation.
Okay, good. All right. What might be the cause in this patient for all this? And mesenteric embolism.
Peripheral vascular disease. There might be a chance of compartment syndrome or DVT, spinal canal stenosis, PLID.
All right, good. Since patient is also suffering from metabolic acidosis, how do you plan to correct hypokalemia?
Okay. For correction of hypokalemia, I have to give the patient sodium bicarbonate
and
hypokalemia. KCl, first of all, I have to range the hypocalcemic in mild, moderate, and severe range. Then, according to the severity, in mild cases, we can give the patient KCl tablets, 2 tablets, 3 times daily. Then if it is moderate, then 2 tablets twice daily. And if it is severe, we have to infusion of KCl.
Yes.
No, I forgot.
This you can revise later, but this is very important. A hypokalemia and hyperkalemia both. How would you manage that? Okay. Right. 13 seconds are left. That's why I was asking. Do you think the patient's condition is amenable for transfer?
I want to manage this. I want to transfer the patient in a well-equipped ambulance with ITU register, nurse, and the technologist, and all the equipments of cardioversion and anticoagulant can be given in the way of hospital.
Good. Okay. Like you were advised, you can transfer the patient. Good. Thank you.